Okay, go ahead.
Fantastic. Thanks so much, Yasi. Good morning, everyone. Welcome. I am very excited to be here with our friends from Blue Cross and Blue Shield today. The time that we are going to have together as part of ISSIP's Excellence in Service Innovation series will be focused on Blue Cross Blue Shield's CarePath AI model, which is a deep learning ecosystem that creates predictive models for healthcare operations. So we're very excited today to have both Ralph Perrine and Natasha Anderson here with us. I'll go ahead and turn it over to both of you to kick us off for today.
All right, thank you all. I'm very happy to be here and appreciate the opportunity. Why don't we start off with Natasha, if you want to introduce yourself and share a little bit about your role, and then I'll do the same, and then I'll get started with our presentation.
Sounds good. Good morning, everyone. So I'm Natasha Anderson. My role here at Blue Cross North Carolina is Director of Healthcare Development and Program Management, and I oversee some of our care management programs and have really enjoyed the partnership with Ralph and his team in what CarePath has been able to provide for our care management programs.
Yeah, thank you, Natasha. So why don't we go ahead and get started, and I'll just share by way of introduction of me and my role. I am Ralph Perrine. I serve in the Innovation Garage at Blue Cross North Carolina, and we've had a great honor and a privilege to be able to look at the horizon and what is changing in healthcare and what kind of new benefits could be offered to healthcare by emerging technology. Like that's been a really key opportunity for us. And it has allowed us to develop a working thesis, if you will, about how healthcare is evolving. What are some of the inevitabilities that we will all need to align to? And then what are the goals we have as an industry and of course as a company? What are the obstacles that stand in the way of those goals? And then how do we innovate around those obstacles? So today we're actually going to have a great chance to talk about one of those really key foundational challenges or obstacles that impacts healthcare. It impacts the experience that you and I have in healthcare. And I think you'll be excited to hear, here's one way how we are innovating around those obstacles. And I'm going to share a little bit about kind of the general context. And then Natasha is going to share a very exciting actual real world use case that actually has happened and where it proves out kind of the efficacy of this approach. And then we'll kind of close up and summarize and welcome questions and discussion as well. So that's kind of the agenda of what we're going to go through today. So I assume you all can see my screen.
We can.
Here, okay, good. So if you think about healthcare and all of the complications and issues that I'm sure you've heard of and even maybe experienced, and you think about those commonly accepted parts of healthcare, things that you probably have heard these words or used them yourself and may be familiar with them. But if you try to think about why does that all exist? How did that come to be? And if you try to reason maybe backwards to a root cause or something, you go, well, why did that happen? And why did we have to have this? And then why does this happen? You know, you kind of go back through layers of things, but they all come back to one root challenge that is at the heart of health insurance specifically. And it has to do with this, is that you're committing to take care of someone's medical needs for some period of time and at a roughly set price, right? But there's some key questions that you will have to operate without knowing. You don't have this information, right? And that information is, you don't know what's going to happen in the future. You don't know who it's going to happen to, and you don't know when it's going to happen, right? So if you think about that, you insure somebody, and then you realize I've got to finance this person as well as several million other people, but I have really no idea what's going to happen, right? And will we be able to cover all of this? And so the industry as a whole, in dealing with that challenge, went down certain roads, right? And made certain choices. In many cases, those choices today, as we look at those choices, we think of them as not very optimal. And oftentimes, many of those key choices about how this industry worked, they're decades old. They come from an era when the percent of the population that was actually insured was much lower than it is today. And interestingly enough, it also comes from an era when the number of illnesses or conditions that were actually considered treatable was actually much lower as well. Like, have you all heard of the ICD-10 codes? ICD, does that phrase mean anything?
Nope.
So what it refers to is the International Conditions of Disease. I think it's the latest acronym of it. But the original version of ICD was back in 1900 or 1908, I think it was. It stood for International Causes of Death. Well, the original ICD-1, which was the standard that healthcare started with around the turn of the 19th century or the 20th century. It had something like 900 codes in it. So there were 900 things that could make you sick and possibly make you die if you didn't have the right interventions, right? Guess how many are in the latest version? So the version that probably most hospitals are using today is like ICD-10. There's about 140,000 of them, right? So you can see how the math equation for health insurance has gotten exponentially more complex, and yet we're still operating with that same core challenge. We don't know what's going to happen. And so we've developed these sort of defense mechanisms almost that end up impacting, honestly, they impact medical practitioners, they impact patients in very negative ways. So we feel that we have to find a way to do something better. It may not be easy, but we have to find a way. So that's what has been a driving motivator for us. And the amazing thing here that has come about, and kind of the thing that we really realized as we've looked at AI technologies and decided to double down on that, is that it gives you the chance to say, what if? What if you could start to predict what was going to happen and who it was going to happen to and when it would happen, right? What if you could do that? What if that became possible, even in gradual increments? What would it mean for our members? And what would it mean for their doctors? And so that brings us to essentially the value proposition of CarePath, which is we have found a way to be able to predict medical onsets and events for specified individuals or groups within specified periods of time. And we are very eagerly trying to unpack all the different ways that that could benefit patients as well as doctors. And in the story that you're going to hear from Natasha, it literally is a case of where we are able to use this emerging technology to buy time to provide proactive care and prevention for patients. There are some other applications of this that we're starting to impact now where we're actually buying time from a financial standpoint. Like we're starting to give financial stakeholders advance notice into emerging risk that are happening and how to better deal with that in a way that doesn't impact the people who need to be able to afford their health care, right? So that is kind of the understory for this, and the context that we're so excited about is being able to provide more proactive, more cost-effective care by leveraging this emerging technology. I want to turn it over now to Natasha and let her kind of tell the story of how she and her team had some goals and some challenges, and then they worked together with us, and together there were some great things that were able to happen. So I will turn it over to Natasha now, and put myself on mute and go let my dog in. So,
Thanks,
go ahead,
Ralph.
Natasha.
Yep, absolutely. In my area of care management, I can provide a little bit of context for those who aren't familiar with care management. And I've been in care management population health for about a little over 10 years now. And we have here at Blue Cross and many other payers and health systems have clinical teams of nurses, social workers, clinical pharmacists, registered dietitians, teams of clinicians who reach out to our members or patients who have complex medical conditions, who have recently been in the hospital, and who need some extra support and advocacy through these really often very difficult life events or conditions that they're managing. So previously, we had been using more of a reactive or retrospective analytics model to identify those members or patients that our clinical teams would reach out to. And that had been working for a while, but we noticed that many of our care managers were reaching out to members who either didn't need our services or the time had passed because it was too late. They had already been to the emergency room and had already been settled in. So we were really not efficient in casting this wider net than we needed to in outreach. And then we heard about, so over the last year or so, we've been working to refine our care management programs and thinking about what are the ways that we can be doing it better. And heard about CarePath in Ralph's area and his team that was leveraging AI, machine learning, and could predict these health events that occur for our members. So as we partnered with Ralph's team, one of the first use cases that came up was in our hospital to home readmissions program. So this program focuses on supporting our members and patients who have recently been in the hospital and are discharged to home. And what we'd like to do is help support that member through that transition, make sure they have what they need at home to have a successful recovery. And so they don't have to go back in the hospital, limit the number of complications that they have. And so we partnered with Ralph's team to see if we could predict those members that were most likely to be readmitted. So based on their prior admission history, based on their diagnoses, based on medications that they were on, which of our members that we're reaching out to that were currently in the hospital were most likely to be readmitted so that we could prioritize those members for outreach and really get to them at a critical time in the process. And in our previous model, we wouldn't get those notifications until well after these members were discharged home. So what we were able to accomplish with CarePath was a model with really high fidelity in predicting those readmissions and ones that could get those members in front of our nurses and our clinical teams while that member, that patient, was still in the hospital. What that allowed us to do was then outreach to that member or patient while they're still in the hospital, help support them through their discharge planning, their transition back to home, and support them through recovery to keep them out of the hospital again, to help support them in improving their health outcomes. And as you can see, early results have been fantastic. We've been able to increase our engagement rate, really improve our effectiveness because more members are able to engage with us. And then because we've taken this more sophisticated approach to who we're outreaching to, that's improved our work efficiency. We're not calling a lot of members who don't need our services. We're really focusing on those members who do need our services and at the right time. And really our goals have been getting to the right member, the right time with the right intervention. And it has just been so exciting to leverage CarePath in this process to really improve health outcomes for our members. And I'm just so excited about the additional models that we're building. So I think Ralph is going to be speaking to additional models, and forgive my cat's tail here that's wants to join in the conversation. Additional models that we're building with CarePath. And with that, I'll hand it back over to Ralph.
Yeah, thank you, Natasha. Any questions, comments so far?
Well, I'm super fascinated about this, and I really like what you're doing. My question is more around HIPAA and how you can get this data and process it. And I mean, it must be a huge obstacle for you guys, because even in my world in IT, I need to be careful what data I put into any models.
Right. Yeah, that's absolutely true. That's a great segue into part of what I wanted to talk through today, was kind of the ethics aspect of this, and what is the proper use of data, and the journey that we went through. Fortunately, there's a few advantages that we have just because of the role that we play and the access to data under US law, the access to data that we already have. And this is a little different from even like European law or some other international jurisdictions. So that was one thing. I'm happy to talk in detail about that. The other one too was, because we had access to this, we have a very significant warehouse of data from our history of serving millions of members, right? That was an advantage, but also the fact that we had a group of people who really understood that data. And so there's a lot of fascinating things happen when you start to create a model for a specific purpose, like the one that Natasha is talking about, where you could realize that something's wrong, right? And then you've got to be able to go back and find a way to correct that in the data supply chain that's now feeding into your model training process. And if you don't have people who really, really intimately understand the data, then that process of really refining and iterating your models, that it becomes just unfeasible, right? It takes too long. And it's, I think, where we've seen an interesting sort of comparison between some of the entrants coming out of the startup world, where they'll come in and go, hey, AI, healthcare, match made in heaven, perfect, right? And then they start to realize they don't have the right to actually use that data. Or they go contract for some industry de-identified data set that's out there, which isn't optimized and isn't optimizable for actual real world usage in most cases, right? And so there's a lot of difference between the popular pre-trained multifunctional type of models that you'll hear about, where it's like we can tell if this picture is a cat or not, right? There's a lot of difference between that kind of a model and then a model of the one that is serving Natasha and her team, right? And so that's been just some of the learnings. And what I would propose to you all is I can walk through this slide 10, which kind of gives you a grounding in just how the factory and the process works itself. And then slide 11 starts to get into that governance aspect, and love to share and talk shop about that. But just to look at this slide for a second, we have the data inputs, and in our case, we have a significant data warehouse. We also have some other inputs, and one of the key ones we call out here is this sort of the social determinants of health type of data, which is very, very important. There are some other ways that we do enrich the model training process with other types of data as well. But then there's the CarePath factory, and we try to be really clear with people that when they talk about CarePath, you're talking about a factory that can turn out a model, right? And then that model can be embedded into your enterprise wherever it needs to be. And one way to think about this is anywhere where you think about there being some really critical business rules that have to advise and guide an operational activity, like in the case of Natasha's case, if you were to look at this from a business rules standpoint, their rules would basically say, look at all the members we have. Of the ones that are going into the hospital, which ones of those are at most risk of having some kind of a painful relapse or readmission when they get out of the hospital? And then they'll have to come back in the hospital. And this could be prevented by a little bit better attention to detail or better care intervention with this person, right? So that's the business rules, right? But you think about the traditional way that we would solve for that, we might have some business analysts who know this data and they would comb through lots of things and they'd start to come up with maybe some SQL queries and some various things. And they might use something like Pega or some business rules engine. And it would sort of sort out like, oh, here's the ones. And they would end up with this list of people, right? Well, the issue with that is it takes a long time to create that. It takes a lot of expertise to create that. And the advantage that you have with CarePath is that we can look through the data that actually documented years and years worth of medical care for millions of people. And we can find those same patterns, but in a much higher fidelity, much more accuracy, much more efficiently than your traditional method of sort of sifting through from a business process standpoint, right? And so that's one way that I think I see a lot of people go, oh, I see what you're doing here, is that we're not really tackling that traditional, big data, deep learning, advanced analytics, the space that you see everybody crowding into, right? Is that we're actually trying to solve the real business problem, which was businesses need to know what to do. Natasha's team needs to know who to call, and they need to know that in the best, most accurate way possible. And so this is how we have worked out the best way to do that, right? And so that's a kind of a view of the mechanics of it. Is like we have an expertise-driven way of wrangling the data, training the model. We do it very efficiently, and this starts to get into the governance and the ethics part of it. Is when we were tuning the factory back in, and this started, late 2018, and then through the process of 2019, it became very clear to us that you could consume a lot of compute resources training these models because the data sets are huge. A lot of times there are a lot of features in them, and then you have to do it over and over again if you're committed to getting it right? And so one of the ways that where we diverge from some other teams, that we spent a lot of time really trying to understand what it would take to create a very efficient model training process, where we literally squeeze those costs down to pennies compared to dollars that other approaches take. And what that lets us do is that if we train a model that has some kind of a flaw, maybe it's got bias in it, maybe it's just there's something inaccurate about it, we have no temptation to try to use it anyway because we've got so much sunk cost into it. Okay, so this is what separates us from a lot of the large players out there. If Natasha's team looks at something and they go, this doesn't seem right, or if our clinical governance team looks at it and goes, this is not right, there's something wrong here, we can freely say, fine, that's it's okay, we'll throw it away and we will do another one. It'll cost us about $6 and take about 8 hours. Okay, so that change, like flipping the economics on their head, is one of the key ways that we can really act to preserve the integrity of the process and really prevent any team member or stakeholder from being tempted to fudge or hedge whenever they're presented with a flaw in the model that's actually ultimately acceptable, unacceptable, right? And we've seen cases, there's been some high profile cases where some large companies with predictive models, and it was shown to be, there was some really serious racial bias in them. And because of, I assume, because of the amount of investment that went into those things, those companies were very slow to come forward and say, okay, throw this away, don't use this anymore. We're gonna fix it, you know, we're gonna upgrade it or something. So that's a problem. Like that impacts people, and we cannot allow that. So anyway, that's one thing. I'll mention one other piece on this. Two things. So about being able to fix things quickly. So this is an interesting tidbit of history from the early versions of the readmissions model that Natasha's team uses. When we were developing like the first versions of it, we were overly excited and surprised and suspicious, because usually your first version is not that accurate. But the first version we did was amazingly accurate. And we were like, oh, wow, we must be getting good at this or something, right? And we looked at it more closely. And what we found out was we were predicting people who were in the hospital and then they were going to come back into the hospital. Like they had some kind of an inpatient procedure or something, and they were going to come back, right? And you know what was mixed up in those? Pregnant women, right? And so over the course of many pregnancies, there are women, they will go in and there may be something done here and then they have to come back in later. You know, that's a pretty normal thing. Well, because they were in the training set, our model really picked up on that. And then it looked like, wow, we were like 99% accurate or something crazy, which was like, okay, there's something wrong here. So that's an example of, because we had a very effective and a very cost-effective and efficient way of training models, we could very quickly go back, oh, okay, let's go back through. And because we have people who understand the data, we could go back in and say, let's make sure that in the recipe for training this model, we're going to remove women who are pregnant, because they're kind of creating a false indicator that the model is misled by, right? And so then once we had done that, we were back down to like, okay, that's kind of where I thought we'd be, percentage accuracy, and we worked back up from there. But that's just an example of one of the many kinds of things that needs to be tuned when you're creating these models. And so that being able to have a very cost-effective, efficient process for iterating, that becomes a bedrock requirement for the integrity of your process. The last thing I'll touch on this slide was that Natasha had mentioned, yes, that there's other models that we have deployed and are deploying, and they correspond to, there's a couple of example ones on the predictions column of that chart, and there's more than those now, but they tend to correspond to the things that we see are the most preventable, and oftentimes the cases that are just the most acute, like in North Carolina's population, which is a population we serve and we're very passionate about. It's sad that there are large portions of our state where the rate of prevalence for certain things like diabetes is way higher than other counties or the national average. And there's lots of reasons for that, but those are the cases where we focus on how do we better serve those communities and those individuals, right? So we're always looking at, and Natasha has actually helped us build a roadmap of like, here's all the different models that we are building and ones we need to build, and then the ones that are built and are running in operation now, they'll continue to be upgraded so that we're always providing the best service with them. So, any questions before I go to the governance part? Yes, Heather?
I did actually have one question. I was just starting to type it in, and now I will stop.
Okay.
It was one of the questions that I had about this was how are the data and insights that you're seeing coming out of CarePath being leveraged to influence broader communal programs or perhaps even government policies? Or are they?
Well, there's a couple of things happening on that front, and Natasha probably has some interesting points to share on that too. But we are in the process of building integration directly to like Epic, the EMR system, so that we could embed these predictions in workflows of providers that use Epic, and we're trying to make it standards based, so the Smart on Fire standard you may have heard of. That way it could work across multiple medical systems. So that's one way. So sharing it with others is one. On the policy side, there has been some interaction between the Blue Cross Association as well as some other entities that are concerned with AI ethics and policy. And definitely, and we'll talk a little bit more about that maybe on this slide here, is that I think this team, it's not really my team, it's actually Dr. Sheila Stallings, who is the chair of the CarePath Medical Council. And I'll share a little bit about that in a minute. I think they are being noticed and recognized as being a group that is really leading the AI governance for healthcare. Like if you want ethical AI in healthcare operations, CarePath Medical Council, that's the model to look at. And if you go back and look at their sort of, and I'll share a little bit more about that, about the history and how it came to be. So that's definitely being influential. But Natasha and her team are involved in a lot more things as well. So I don't know, Natasha, if there's things you want to mention as well.
Yeah, no, I think that's a great question. I would really say that this governance structure, to Ralph's point, is really where I've seen the impact and influence, especially more broadly. I think Ralph, Dr. Stallings, and the council that we've set up has influenced other organizations. As Ralph said, we've shared sort of what we're doing. And so I don't know of any specific policy changes that we've made as a result of CarePath at this stage, but I know we here at Blue Cross North Carolina have been trying to be really thoughtful about how we implement these types of AI models, particularly when it directly impacts member outreach and engagement. As Ralph mentioned earlier, there is potential for these models to further the health disparities and racial disparities that exist today. And so we want to be very intentional about not deepening those disparities, but rather reversing those disparities and being very intentional about reducing health disparities.
Yeah.
Can I ask two other quick questions? So one thing that I'm curious about. So how's the outreach working? Do you have a dedicated function? And also one thing when you do this kind of outreach, you typically want to try to avoid reaching out to people that are deceased, so the widow or widower doesn't get an invitation for the lost one to go to the hospital. So do you have any way to correlate that or check that, or is it a hit and miss, or any thoughts on that? So two questions: who's actually doing the outreach, and do you have an ability to do that validation?
Yeah, great questions. Yep, so it's our clinical team, so our nurses, our social workers who are making the direct outreach to our members. They do it normally over the phone. We do have a care management app that we can leverage as well, if that's what you're asking. And then in terms of members who may be deceased by the time of outreach, we do have a few checks and balances in place that help filter those members out of our processes, so we don't make direct outreach to those members. Same with members who may be moving to hospice or in a skilled nursing facility where they have some wraparound health support services. We filter some of those out of our processes as well, but we don't catch them all. I'll be transparent, we don't catch them all. And so there are times when the nurse is making outreach to a member and they have since passed, and we note that in our system so that we don't contact that member again.
Yeah. Does that help?
Yeah, a lot. Yeah.
Yeah.
Very good.
Thank you. Okay. And Heather, I think to your question to one organization where Natasha and her teams and then the CarePath Medical Council work has been presented was at the Compliance Council Summit. So I don't know if you're familiar with that group, but it was a great chance. You know, they're I think leading some really good awareness in the policy space around health equity in general, right? And so things along the you know, there's a lot of shortcomings, honestly, in the healthcare space, the traditional healthcare space around race, ethnicity, and language, particularly like incompleteness of the data that's been captured. And then kind of on the new, you hear the term SOGI, the sexual orientation, gender identity. Again, for many organizations or facilities or even just data enterprises, this is like a new thing for them, unfortunately, I guess, right? That it's not something that's been tracked with the degree that it should have been. And then, of course, I think a lot of people are very familiar with determinants of health and as a category of data, and also how that oftentimes there's an interplay there with equity as well. And so, you know, our purpose statement as a company is make healthcare better for all, capital A, capital L, right? And try to really move past what has unfortunately been sort of the norm or the accepted practice, I'm afraid, in some of our past decades in this industry, right? But anyway, that's an organization that you might want to be familiar with. And the other one was the Blue Cross Blue Shield Institute, which is part of the association, and this is the governing arm of that all the Blues license their you know, the logo, and they comply with regulations. Essentially, this group coordinates and orchestrates the collective behaviors of the Blues network and Blues system, so that there's continuity of experience and transactions and so on for all the members, regardless of what state you're in or whatever, right? Almost a bit like the European Union with the European states, perhaps, right? Is the way the association works. But anyway, the Blue Cross Blue Shield Institute is a policy arm again, and they've actually come and consulted with the CarePath Medical Council for guidance on ethical AI and health equity and things like that. So it's another example of where there's starting to be an influence there. Okay, so what I was going to offer to do here was to go through on slide 11 and 12 and just unpack a little bit about the way that we came to really take seriously ethical AI and how we govern that and use that. Back in, I think it was early 2019, we were looking at different literature. At that time, we had some early models, we had some early like sort of test results, and we already felt at that point this is going to become a serious thing. It's probably going to be pretty ubiquitous in healthcare, the ability to use predictive capabilities across different parts of healthcare. And fortunately, we had come across some literature as well as some influence from some groups. And one of them that I will credit readily is, if you've never heard of the newsletter and the community called Exponential View. It's led by Azim Azar out of, I think he lives in London. That is a wonderful newsletter. There's a free version and there's a paid subscription version, but either one is very valuable. But it's a great way to keep your finger on the pulse of emerging technology issues. And I have to say, thanks to reading that, it really, I was really struck with the importance of you are going to have to understand AI as not just a cool technology. It is going to be a matter of integrity and ethics and reputation. And so, of course, that for me as a lifelong technologist, I went through all the different waves of like, from literally the early 90s, multimedia CD-ROM. I wrote some of the first code that ran video on computers, personal computers. And, the idea that, oh, this has ethical dimensions, you better be careful, right? That was kind of new to me, right? And so we worked with our leadership team, our legal team, and our ethics and data privacy folks inside the company. And we decided to engage a team out of the EU who had notable experience in the GDPR legislation and were willing to come at it from that angle, which we felt was a healthy influence for us. And I don't know how deep you want to get into this, but there's some really interesting differences between the legal structure in the US around data privacy versus the EU.
I live that every day. I live that every day.
Is that okay? That's familiar territory to you. Yeah. So what for us, I think the way it really felt like it'd be a good influence is because in some ways, if I had to describe, I'd love your opinion on this too. But if I had to describe, like if I had to summarize sort of the three ways of the world on data privacy, China is like state first. Like if it hurts the state, then we do not allow it to happen. If it helps the state, then we're not so worried about everyone else. That's the perception. That may be a bit unfair, right?
And as long as they have a copy of every packet.
Yeah. Well, and on the EU side, it's the part we are going to protect the individual, and if that harms the state, then there's something wrong with the state, right? And we need to fix it, right? So almost the opposite. And I feel like the US kind of, they're not sure where they're going, and it depends on who's donating the most to the congressman or something like that. That's terrible. I shouldn't be so cynical, but and so for us, we felt like, well, if we go and work closely with these folks who are really coming in from an influence of the EU legislative framework, that'll be a healthy influence for us, because our desire is to really serve our members and their privacy and their benefits and so on. And so we ended up doing that with them. We had a several months long engagement, and they came in and really helped us structure an approach. We actually had some other individuals from other organizations involved as well. And one of the things that came out of that was they said, you really have to have a governing council. If this were some kind of steady state thing that we were all very familiar with, you could probably write a few lines of code and it's just a business rule, right? It's like if it's this and this, it's fine. If it's not that, nope, it can't happen, right? But you're just not in that kind of space. And so you're going to need some kind of a council of people who are cross-representation of legal, privacy, compliance, as well as technology, data governance, as well as people who understand the emerging technology in the AI space. But you are going to have to especially put heavy weighting on the clinical side of this. And we were so lucky that we had some people who were kind of all these different disciplines, and the clinicians themselves were very helpful, because they weighed in very heavily and said, you have got to make this so that if there is any doubt about whether this is medically effective or medically acceptable, then you have got to have the teeth to be able to say, no, this can't be used, right? So out of that was born the CarePath Medical Council, which is a council, and the sort of the description of it is here, is that this group has formal authority to stop something from being implemented in healthcare operations if it is believed that there is some sort of harm or bias or something that could arise out of this. And it is also weighted so that even if the legal team, the data privacy folks, the other disciplinary stakeholders, if they all say, yes, this is cool, this is great, but the clinicians say, no, we do not believe this is medically useful or safe or effective, they always outweigh, right? And of course, they can't vote yes and then do something illegal either. That there's, we've put together some voting rules to guide those kind of things. But this has been a really exciting learning path for us to learn how to enter new territory. There's clearly some new and very exciting innovations, but at the same time do so in a sober-minded way, so that we ensure that we're being transparent and we're really making sure that we're providing benefits to people that are real, right? Rather than this is just cool stuff, and so everybody thinks we're cool or something, right? So that's, I'll pause there, maybe for some questions, and if it's of interest, we can kind of go through kind of the ecosystem view and maybe how some of these checks and balances and processes work together. But I do want to be mindful of where your curiosities lie and what you like to explore here.
It's only me talking, so I don't know Jim and Heather and Yassi. If I ask too many questions, you guys have to stare at me angrily over the video. Shut up.
You know, we just jump in, Ulf. It's fine.
That's right.
So,
Yeah.
Ulf, you always ask great questions. And Ralph, by the way, Ulf is the president of ISSIP. So we're really happy to have him on this call.
Thank you. Yeah.
My question is, you know, how can ISSIP and the ISSIP community help you in moving this forward, if that is of interest? And also, how much of this CarePath AI ecosystem is closed and how much of it is open? I mean, is there interest in collaboration with the outside community?
Absolutely. And like I mentioned before, we have had it's going on almost 2 years now, collaboration with UNC Medical System to, like I mentioned, building integration, direct integration, so that they can have CarePath predictions flowing into their system and make it available to their doctors in their workflow, right? And the idea is that they would be a showcase for other similar systems that want to do the same thing. The way that you can help, I think, is maybe if I talk through that from a standpoint of like describing what our goals are and kind of the need and why, you know, maybe that will give you some ideas, but I may have some thoughts as well. But essentially, this is solving for that fundamental weakness in healthcare. Is if you don't know what's happening and you can't be proactive, then you just can't serve people as well, and people will not be as healthy and they will not live as long. Like, there's some serious downsides for not getting this right, you know. And so that's why we've been so passionate about being committed to this. We need to take predictive capabilities and make them ethical and make them available in a cost-effective way as broadly as possible in the healthcare system. And it is really just like, if you look at and talk with the people who are doing the work, it is non-glorious, pretty mundane work. It's very tedious, it's very complicated, and it will never be part of a Coke commercial or something, right? It is just not that sort of cool, buzzy thing, even though it may look that way from a distance, because the urgency is not having that kind of foresight costs people money, it costs lives, it costs time. You know, it's a very costly thing to be ignorant of the future. It's a horrible thing, right? But we're trying to address that and address it in a way that makes it available effectively and efficiently and ethically as broadly as possible across the healthcare system. And so I think that's where I would want to ask for your help and maybe champion that. It's like, this is not coolness. This is not, you know, oh, advanced technology. This is humble and very urgent work. And if we don't do it people suffer, and if we do it in a limited way, or it's only implemented in a limited way, people suffer. It's the same thing, right? And so I think that's the part that I would really want to emphasize to you in terms of our goal and our passion around that, is that we really are trying to find ways to, this capability needs to be everywhere. It needs to be available everywhere. How do we do that, right? That's fine. So I'll pause there. How do you think about that? And are there things that you would say, oh, wow, here's what I would like to do to help that?
I have exactly a question.
Yes.
That. So when I talk about data analytics, and by the way, so I head up service product management for Aruba, part of HPE, and I've been leading a lot of R&D initiatives around data analytics, both at Cisco and at HPE. So when I talk about data analytics, I love to state that data is the new oil and analytics is the new refinery. And when you look at how to make money on this, so you have business value yourself. I'd see this as a gold mine to sell to the pharmaceuticals, and maybe even to have some exchange with God forbid, but some of your competitors. So any thoughts around that? Because the more data you have, the more valuable it is. And from a regulatory point of view, can you actually make a business out of this and sell it to the pharmaceuticals? Because I think this is, they would, I'd say, go walk over dead bodies to get this, right?
Yes, yeah, for sure. Well, so a couple of, there's a few questions you've had in there. It's like, have you looked at gathering larger data sets? Yes, we have, and we have a group of people inside the company that are focused kind of on data acquisition, I guess you'd call it. We have, one of the key targets that we have is the national data warehouse that is aggregated from all the blue plans, all the blues. And we actually deployed a version of CarePath into their data center so that we could begin to train models. The vision there would be that, at least among the Blues network, that again, they should all democratically have access to this kind of capability, and it should just be, and the other benefit of doing it at the national level like that is that there's data patterns in that larger set of data that are not present in the North Carolina set of data. Like, our data is really primarily North Carolina's medical history, which is a fascinating and amazing set of data. But there, for example, we don't have that many heart transplants in North Carolina for whatever reason, right? There's not enough. We had an amazing cost-saving use case that related to heart transplants. We actually could not pull it off because there's not enough heart transplants in our data set to make us have a reliable model. You cannot train, not enough to train a model. There would be at the national level. And so that was the motivator. Now, on the association's side, in the National Data Warehouse, their plans to collaborate with us and roll this out were very impacted by COVID, and then a number of things that had to happen at the association level due to regulatory changes and things. There was a bunch of projects they got slammed with, and they were not able to focus on this to the degree that we would have, and they would have liked. But we have high hopes in 2022 to bring that forward. As far as, I think the other question you asked was about from a regulatory standpoint, could you do things like offer this to pharmaceuticals or things like that? So we are exploring that. Like, we do have a go-to-market plan where we want to be able to make this available as a very cost-effective, and try to avoid, honestly, the business models that we've seen a lot of others play, where they try to sell like this enterprise platform, and then they end up running into competition with Teradata and Data Haiku and Cisco and or Oracle and tons of other players out there that have already well occupied the enterprise data space, And whereas in our case, if I had to say what I think our real competitor or what we're displacing, I think it's like, you know, the Bureau of Labor data shows that operations research analysts, who people cook up business rules, that job is supposed to grow at 25% over the next 10 years, which is way higher than the average job rate. Why do you think that is? Well, there's so much rampant change and everybody knows their business rules are outdated. They're not efficient enough. They've got to do something. So if you don't have an efficient way to do this, like with a CarePath model, then you will have to hire a ton of more, you know, business analyst types to go try to write business rules and keep up, right? I think that's an interesting, different way. And we could come in and price it differently and say, here's a much more cheap, cost-effective way to make this powerful technology available. On the data, you know, sort of the data laws and things like that, as a payer, as a health insurance company, we have a safe harbor, I guess, if you will, that is based on us being a health services provider. There's a phrase, a specific phrase, but in the course of healthcare operations, our healthcare operations, we will encounter and possess and use data. And as long as that data is for the purposes of benefiting the member and carrying out the necessary healthcare operations, then it's judged to be that you have a legitimate purpose for it. I think where, let's say that you were to make it available to a pharmaceutical company for some purpose, there's some other interesting use cases that we're being approached with that involve planning, informing someone's plans or investments based on a really detailed understanding and knowledge of the actual medical needs that are likely to occur in a population or something, right? So I think where some of that will hinge is, are you disclosing or using this data, which is really to be used for the benefit of these people's health, right? Is it being used for the benefit of their health, or is it being used for some other commercial benefit? And if so, there's definitely some examination that has to be done there. Like under European law, if I am recalling this right, you need a direct consent from that person that's like, yes, I'm allowing you to use my data for these purposes, right? US law is sort of getting there, but there's still a lot of big gaping loopholes in that. And so it would definitely be something, I think, when we looked at individual business cases, we'd have to have a lot of legal guidance and approach that very carefully. That said, I think the opportunity to use it for the purpose of benefiting people's health and making their healthcare either affordable or more effective, more proactive, I think there's a world of opportunities in there that exist under the current legal framework, right? So we don't have to go renegotiate laws to accomplish the good that we're trying to accomplish, I think.
And Ralph, I know we're 1 minute over. I don't know how we're doing on time. I do have a follow-up question.
Yes.
So I want to. So on the, you know, how can ISSIP help? In our community, we have lots of experts who are focusing on AI ethics. The question is, and there are lots of organizations that are focusing on AI ethics, right? So the question is, what unique problem would our community, together with you, try to solve that others are not trying to solve?
And a unique problem specific to AI ethics, you mean?
Well, you know, going back to my previous question, how can ISSIP help to move this forward? What I heard was, you know, in the area of AI ethics, we could do something together.
Mhm.
That's what I heard. Correct me if I'm wrong.
Yeah.
And then you said, so what do you think?
Oh, yeah. Yeah.
Right?
Right.
And we're brainstorming here.
Yeah.
So, you know, I'm thinking ISSIP could potentially do something in AI ethics, but then what is it specifically that, for example, IEEE is not doing? And, you know, it has to be something unique that we can together define. And that's how ISSIP work is done. You know, we
Yeah.
have members who are passionate in solving a problem, and then we get the
Mhm.
community together.
I like that. Well, one area, and Natasha, you should maybe chime in too, because I'm sure you've got some thoughts, but one area that we're focused on right now is the implementation and maturity of what we call a bias protection framework. And this represents a maturity step for the CarePath Medical Council, because the original way the council was formed was that it was really a scrutiny, it was an audit. Like the people who produce work product, essentially the people that develop the model, they will bring their work product to the council. The council will tear it apart and look at it and ask questions and do all kinds, and then decide based on what they saw. They would decide with it's solely their discretion. They would decide whether or not to allow this into healthcare operations or not, right? And they have the authority to go back and say, nope, you can't use this until you fix this and this. And they do that sometimes. Or they could say, yes, this looks good, we're gonna let you go, right? But the bias protection framework now kind of builds on that by standardizing the artifacts that are actually created during the process. And it has a big emphasis on kind of reaching outside of the model training process to actually looking back at the data and where the data came from. So actually applying checks to the data so that we could, for example, catch cases where, you know, this data set reflects that African Americans were actually underserved in this community or at this facility. And so that now is a problem for the training of this model. We do not want a model to start picking up and mimicking the behavior, inappropriate behaviors of some data history, right? So the bias protection framework will give us a deeper view into those kind of things. It's a way of us increasing our safeguards. What I think is a possible opportunity to collaborate would be in standardizing and maturing that, and maybe aligning that to other emerging frameworks, including, like I read through something, there was something that was being proposed by the IEEE. We see a lot of different proposals, and I think what we could offer that, I think what you have a lot of these is you have some very, very highly intelligent and experienced practitioners or experts, but maybe they don't have the front row seat that we have in actually deploying this and using it in healthcare and learning those real world problems and dilemmas, right? That Natasha and her team and the people we're working with, like we've got some real experience with some of those really challenging situations, right? So I think by bringing those two together, that could be super useful, because we would love to see what the industry expertise and people who have time to really think and study this a lot, what would they have to say about the bias protection framework? How would they help us improve it? And at the same time, I think they would benefit from the fact that we've got real world scrapes and bruises from actually doing this for real people, right? And it's sort of, having been kind of on both sides of that, if there's someone who's got really practical experience in it, they can help me decide where to really focus. Like there's certain things that could seem intellectually beatific to me, and I could spend a lot of time on them, and then I come to find out that's not really what real world practitioners are wrestling with anyway. So I don't need to elaborate so much on that. I need to really help them solve for this, right? So I think that could be a very symbiotic relationship there. That's an idea there. Natasha, would you disagree, or we have other thoughts? Or
I wouldn't disagree, Ralph. I think I was thinking the exact same thing, that maybe we can learn from each other with the bias protection framework. I think that's something that can set apart these AI models from others that are out there, is if we have a framework in place that prevents bias in the first place, and we don't have to discover it after the fact. So
Yeah,
agree, 100%.
That is really helpful. I don't know what others from ISSIP side think. But from my perspective, I think that's a great great feedback, and I think we could discuss it, and then you know, come back to you with more thoughts.
I would, another one that might be kind of related, it's just something to think about, is that, you know, you think about like in the case that Natasha was sharing with you on this slide here, she talked, you know, you can see there's some definite changes in the performance, like this 12 to 57% or 40 to 55, things like that. The ability to gather that information and then share it so that stakeholders, whether they're community stakeholders or executive stakeholders within an organization or others, so that they can kind of experience and interact with the actual results of this, I think is another, that's another possible thing that could be, it sounds like it could be interesting at a consortium level or an industry or academic level to say, almost like how Johns Hopkins was tracking the COVID stuff so well in the pandemic, you know, like what if there was like an industry-wide dashboard and it's like, this is where we're actually moving the needle on key health concerns. Readmissions is one of them. Like the average readmission costs $14,400 as of 2016. It's probably higher now. And some of them are a lot higher than that. And 2/3 of the different categories of readmissions cost more than the initial admission into the hospital. So having a relapse and going back in, that costs more than the first time around the original treatment, right? In 2/3 of the categories. So this is a big deal. Like this is a major concern for every hospital CFO, every payer CFO out there, right? Anyway, so the idea of a dashboard, that's another one that might be interesting too. So bias protection framework and dashboard might be some interesting ways to look at this.
Those are both great ideas.
Yeah.
So thank you for that.
Thank you all. Thank you for the great conversation.
Got some homework to do.
Yeah.
This was, I really appreciated this session. I mean, it's a big passion of mine, and I think what you guys have done is extraordinary. When we can use analytics to actually help saving life and give people better care. Of course, saving money at the same time is a bonus, but at the end of the day, helping people is really good.
Yeah.
Thank you.
So
yeah, it really matters.
Thank you so much. I know Heather had to drop off. You know, I really want to thank you and Natasha for this great talk, lots of food for thought. And, you know, we'll definitely be in touch. So thanks everyone for joining. And with that, have a great day.
All right. Thank you all. Take care.
Bye-bye.
Bye-bye.